Medical Tourism Corporation interview with Dr. Vivek Jawali. Dr. Jawali is a pioneer in cardiac surgery in India and has performed more than 15,000 cardiac surgeries. He has presented more than 200 scientific papers as well. Dr. Jawali was the first doctor in India to perform awake cardiac surgery and has since performed the procedure over 500 times throughout the world.
Most of these patients were not straightforward surgeries. I don't remember from US any straightforward, simple, dumb coronary bypass. There was a patient from Chicago who owns a ranch asset. His name is, I think it may not be appropriate, I would just say WS. I would put it in there. The elderly, very nice gentleman, 81 years old. He had a tight calcific aortic stenosis with a triple vessel coronary artery disease and a chronic atrial fibrillation. I had to do for him an aortic valve replacement using a tissue valve, do a triple vessel bypass, and also do a maze operation. This is a major surgery for 81 years old man with a badly hypertrophied heart. He did well. Then there was another guy, one of the recent patients was from Alabama. This man was a middle-aged guy from a good background, very educated, very fastidious. He had a chronic severe mitral valve regurgitation and a chronic atrial fibrillation. And he was very adamant that he wanted a good mitral repair and not replacement. But this patient had a bileaflet prolapse. And a lot of people may feel that they would just replace it. We said that we will do a repair and not replacement. And we could do a good repair for him, and we did a cut and sew maze, and he went back into an atrial sinus rhythm. He went back with a repair. On the echo there was a 0 MR, and the importance of doing such a surgery is that if there is a repair, there is no anticoagulation, no blood thinning medicines. If the rhythm goes back into sinus, then after some time he's on no medicines, he's on a robust lifestyle. He works normally, he eats normally, and that's good, and we were very happy. He's a very satisfied patient. I think you can take his whereabouts from Rashmi. And there was another patient from Key West. I was talking to you about him just now. He also had a very severe aortic stenosis with multiple syncope and cardiac failure, and he did well, he turned back. Most of the patients that we had from US, there were 2-3 prominent things about them. They were not straightforward cases. They had indulged in a lot of research. Unlike patients coming from the East, these patients do a lot of research and come, so they know what they are coming for. And they were very well informed about their own problem. So it wasn't a big issue for us to make them understand anything. They knew everything, they had done a lot of research. See, I have been mostly trained in India because the amount of opportunity you get to operate here is there nowhere else in the world. My training began in 1979, and I came out to Bangalore to establish a heart center, and between that period, in 1984, between that period, I had done in Bombay 2,500 hearts. Nobody that I know of in the West has had an opportunity like that. So I stuck here. What I did was, now and then, as some newer procedures came up and I needed that polish on my experience, I kept going mostly to the United States. But I have been to France, to Germany, to UK, to Australia, to Sweden. It was mostly to the people or to the institution who were doing most of it in the world, to the cutting edge, to Leipzig. But much of my visits were to the United States because there were a lot of people who were doing things which I wanted to learn. For example, when the emergency coronary bypasses came in the patients who had unstable angina or recent infarcts, there was a guy called Stephen J. Wolf in Des Moines who was doing really cutting edge, daring things about this. I went and stayed with him for a while. Then there were people like the Duke's University guys who were doing the maze operation. They were the earliest experience. There was a guy called Ramdas Batista who was doing this LV reduction surgery in Brazil, and I went chasing him to Brazil. And then there was a guy called Calafiore who started the earliest experience of minimally invasive bypass surgery through small thoracotomy. So I went and lived with him in Chieti in Italy for a while. Dr. Subramanian in Lenox Hill Hospital in New York, who was one of the earliest again to do the mini thoracotomies. Cosgrove, Toby Cosgrove in the Gillimov in Cleveland Clinic, when they began their first experiences of minimally invasive valve replacements. I went there. The beauty of this combination is that here I am operating huge every day. Today we do anywhere between 12 to 14 open hearts every day. Okay, those days I used to do myself 4 to 6 every day. I now also almost 3/4 of the list is done by me. So when you go to some people like that, you are an experienced surgeon. You go to these centers and have a couple of dinners with these guys, watch him do 5 or 6 procedures, and then spend a couple of nights in their ICU talking to the juniors, talking to the nurses. You get everything that they have learned in print and in fine print. Okay, what they would not tell you, the negatives that would come from that. So when I come back, I have a huge load of the similar procedures waiting for me. And in a couple of months, I am on par with them. And if that is something good that should be done, in a couple of months later, I'm ahead of them. And that is the beauty of being in a country like this, which has a massive load to operate, which has come of age because now funding is not a problem. If you go around in India, you would see that the infrastructure has come of age. There are at least 300 hospitals in this country which are good, where I can practice state-of-art medicine. What is the special thing about my practice here locally? See, the hospital in which I operate here is the Wuhan Hospital. That's the only hospital I operate. I don't go anywhere else. This is a JCI accredited hospital. We are franchised with the Harvard Medical International, so we are audited regularly. We are looked at critically. And this is a well-equipped hospital. Its management is very professional. It's not managed by doctors, it's managed by the MBS. And where you talk about technology, my cutting technology is mostly adult, personally. And my cutting technology is more, my expertise is more in the area of coronary bypass surgery and in the area of valve surgery, surgery of heart valves. The special things are almost all the operations that I do in bypass surgery are off pump. I have a huge experience in performing off pump bypass surgery by global standards. I have been doing bypass surgeries off pump without heart-lung machine since 1992, when it was not even a thought in the United States. In the United States, it became a rumble and a major talk since 1996 and became a reality in 1997. We have done by now, myself, about 7,000 off-pump bypass surgeries, which is a good experience, and now we are very lubricated in this whole affair of doing off-pump bypass surgeries. So all kind of cases are done by us off-pump. A large number of them now, since last 7 years, I have been doing under high thoracic epidural without putting endotracheal tube awake. But then we are choosy about that. The good deal to do a cutting edge bypass surgery, according to me, which I perform, is A, don't do it on pump. B, try and see that no blood transfusion is given. C, give at least 2 arterial grafts so that if the patient takes good care of himself, he may not come back for a second surgery. This we do routinely. And in some of them, we may not put them on ventilator, may not dope them, and they may be very fresh, not ventilated, not intubated at the end of surgery. So this is a good deal. They fast track well, they have a very low morbidity, and of course their long-term results are good because they got arterial grafts. In valve surgery, we are doing more and more repairs. We are very bullish with doing maze operation for patients who have got atrial fibrillation. There are different technologies for atrial fibrillation, of radio frequency ablation, cooling techniques, but I feel, notwithstanding all the sophisticacy, even today, the cut and sew maze is a guaranteed job. And we have largest experience of cut and sew maze. And cut and sew maze works very well in the hands of the surgeons who have a lot of experience of that and who can do it quickly. Because surgeons who cannot do it quickly, they are worried about morbidity. We were one of the earliest in the world to start off-pump bypass surgeries. We were one of the earliest in this part of the world to start minimally invasive bypass surgeries. And we did the world's first major open heart surgery awake without any ventilation or without any ventricular tube. This was a 78 years old man who required an aortic valve replacement and a triple vessel bypass. We did it in 2000 without any endotracheal tube or ventilator or any sedation under high thoracic epidural analgesia. We have now a very good experience of that. We have done more than 600 such cases. We have a lot of papers published on this issue, and we certainly have world's largest experience of doing awake cardiac surgeries under high thoracic epidural analgesia. See, we are AJC accredited. B, we have partnership with the Harvard, and C, we have a lot of payers who send their patients to us. So our results are tracked, and we do risk stratify. But if you say roughly, put everybody together in one basket, I would say the mortality would be around 1.2%. Okay, but then in each cohort of risk, the risk rises. So when you talk about an individual patient, then you have to stratify his risk, either Euro risk or by STS risk stratification, and then we can say. But if you bluntly put it as a overall in one basket, I would say 1% mortality, putting valves, coronaries, everything together. What's my message to a potential patient? See, the patients come to us from outside India, from have-not and from haves. Okay, if you talk about the haves, which is from the Western world, they would come to me either because they can't tolerate waiting in the long waiting queue, or because they have lost insurance and they find the whole thing very expensive. These two are the classes which come to me. I think they can come, they need to do research, comparable research, decide what they want, communicate with us on mail, phone calls, assure themselves that they are going to get what they want. They would pretty much get what they want. There are a lot of fanciful things that go on the internet about the endoscopic surgeries, robotic surgeries. Those things, believe me, they have not arrived yet, even in the United States. Okay, most of the surgery which is reliable, which is low mortality, which is low morbidity, and which will last long is mostly traditional surgery with a full incision or mini thoracotomies, and a traditional either repair, replacement of valves, traditional good multi-vessel complete bypass, but which can be done up pump with arterial grafts. That can be pretty much done with excellent confidence index here, and they can come here. What they would get here is a good cutting edge, reliable long-term surgical result.
Medical Tourism Corporation facilitates affordable medical treatment at world-class international hospitals. Fill out the estimate request form on our site for a free quote and more information.